If you are currently managing blood pressure, whether for yourself or a loved one, it is imperative that you take a moment to pause and consider a critical piece of medical advice that may be dangerously outdated for your specific age group. For years, the standard, universally accepted target for blood pressure management has been 120/80. This number has been held up as the gold standard, the benchmark for cardiovascular health that doctors and patients alike strive to achieve. However, emerging medical research and a deeper understanding of human physiology suggest that this one-size-fits-all approach is not just ineffective for seniors, but in many cases, actively harmful. The advice that works perfectly for a 35-year-old body, a body with resilient, flexible arteries, can pose a serious threat to the complex aging vascular system of a 70-year-old individual. This discrepancy in treatment targets, often overlooked in mainstream medicine, puts millions of seniors at unnecessary risk of overtreatment, overmedication, and serious adverse health events, all in the pursuit of a number that was never truly designed for them in the first place. This is not a theoretical concern. It is a clinical reality supported by extensive data. A landmark study published by the Journal of the American Medical Association, JAMA, followed more than 4,700 adults aged 65 and older over a period of 5 years. The findings were truly extraordinary and challenged the prevailing medical dogma. The study found that seniors who were aggressively treated to reach that iconic 120/80 target had a significantly higher rate of serious adverse events, specifically a 21% higher rate compared to those who were managed at a more moderate target. These adverse events included critical complications such as fainting, debilitating falls, acute kidney injury, and dangerous drops in blood pressure, hypotension. A 21% increase is far from a statistical anomaly. It represents a clear and concerning pattern that demands attention from both patients and healthcare providers. It highlights the urgent need to reevaluate how we approach blood pressure management in older adults, moving away from universal standards toward individualized care. The fundamental issue lies in the fact that the physiological environment of an aging body is profoundly different from that of a younger adult. The original guidelines that established 120/80 as the benchmark were largely derived from studies on middle-aged adults, often with a heavy emphasis on men under the age of 60. The aging process naturally brings about significant changes in the cardiovascular system. After age 65, your arteries undergo a process known as arterial stiffening. To illustrate this concept, think of a brand new, pliable garden hose that responds easily to changes in water pressure versus an old, rigid hose that has been left out in the sun for decades. The old hose loses its flexibility and requires a higher baseline pressure to push the same volume of water efficiently through the system. Similarly, an aging arterial system, having lost its elasticity, needs a slightly higher pressure to maintain efficient blood flow to vital organs, including the brain, the kidneys, and the limbs. This physiological reality means that a pressure reading that would be considered elevated in a younger person may be perfectly normal and even necessary for a senior to sustain adequate organ function. The evidence supporting this individualized approach for seniors is compelling. Researchers at Johns Hopkins University specifically investigated the effects of different blood pressure ranges on cognitive function in older adults. Their findings indicated that in adults over 70, a systolic blood pressure, the top number, falling between 130 and 145, was actually associated with better cognitive function and lower rates of dementia when compared to those whose blood pressure was pushed down below 120. This finding is counterintuitive to the prevailing narrative, yet it makes perfect sense when considering the principle of perfusion. Perfusion refers to the critical process of blood delivery to tissues. An aging vascular system, particularly one that has lost elasticity, requires sufficient pressure to ensure a constant and reliable supply of blood to the brain. If blood pressure drops too low, especially during periods of stress or movement, the brain may experience reduced perfusion, which, over time, can contribute to cognitive decline and other neurological issues. Therefore, if you are an older adult who finds your home blood pressure monitor consistently reading in the high 130s and feel anxious about it, take solace in knowing that for your specific physiology, that number may in fact represent a healthier, more appropriate range than a significantly lower reading. The key is context, and your personal target must be discussed specifically with your doctor, taking into account your age and overall health, rather than simply applying a population average target. A related and often overlooked danger in the pursuit of low blood pressure is hypotension, which simply means blood pressure that is too low. Hypotension poses one of the most significant yet underdiagnosed threats to senior health today, particularly when compounded by overzealous medication. Consider the case of Margaret, a 74-year-old retired school teacher from Knoxville, Tennessee. Margaret came in for a consultation after suffering her third fall in 2 years. Her first fall resulted in a fractured wrist, the second left her with bruised ribs, and the third, a fall in her bathroom at 6 a.m., left her stranded on the floor for 2 hours before she was discovered by her neighbor. When a thorough review of her medications was conducted, it was found that she was taking 2 different blood pressure drugs, both prescribed with the aim of getting her numbers as low as possible. Her morning readings were consistently around 105/65, a dangerously low level for a woman of her age and specific physiology. The critical science behind Margaret's experience involves orthostatic hypotension. When a person transitions from a sitting or lying position to a standing position, the body must rapidly redistribute blood upwards to ensure adequate flow to the brain. In younger individuals, this process is instantaneous and automatic, managed efficiently by the autonomic nervous system. However, in people over 70, the reflexes that manage this process become sluggish. Orthostatic hypotension occurs when, upon standing, blood pressure drops sharply before the body can compensate, leading to dizziness, lightheadedness, and a loss of balance. These symptoms directly caused Margaret's falls. It is vital to recognize that falls are the leading cause of injury-related death in adults over 65 in the United States, making this physiological issue a matter of life and death for many seniors. A study from the University of California, San Diego, further underscored this danger, revealing that seniors with orthostatic hypotension had a 54% higher risk of cardiovascular events and a significantly elevated risk of cognitive decline. After carefully adjusting Margaret's medications in consultation with her cardiologist, establishing a more appropriate blood pressure target that was slightly higher than her previous goal, her falls stopped entirely. She described the change as getting her life back, no longer living in constant fear of simple movements. The practical takeaway here is straightforward. If you are taking blood pressure medication and experience dizziness when standing up, lightheadedness, or instability on your feet, it is essential to communicate these symptoms to your doctor immediately. Measuring your blood pressure both sitting and standing can help uncover this critical difference and allow for a more precise, safer treatment plan. In addition to physiological and medication-related issues, accurate diagnosis of hypertension in seniors can be significantly complicated by measurement errors and environmental factors. This brings us to the common phenomenon of white coat syndrome, a condition where anxiety triggered by the clinical environment artificially inflates blood pressure readings. Studies published in the European Heart Journal indicate that up to 30% of seniors diagnosed with hypertension based on clinic readings actually have normal or near normal blood pressure in their daily lives. The clinic environment, the unfamiliar room, the waiting period, the anxiety associated with a medical professional taking a reading, triggers a stress response that can temporarily elevate blood pressure by 10 to 20 points. While this effect is well documented in younger populations, it can be even more pronounced in seniors because the aging cardiovascular system may respond more dramatically to psychological stress. To counter this, seniors are strongly encouraged to use a quality home blood pressure monitor. These devices are widely available and relatively inexpensive, typically costing between $30 and $60. The recommended protocol involves taking readings in the morning before consuming caffeine or medication, after sitting quietly for 5 minutes, and taking 2 readings with a minute between them. Maintaining a log of these home readings over a 2-week period provides far more clinically meaningful data than a single reading taken in a doctor's office where the patient may still be feeling the stress of finding a parking spot or anticipating a diagnosis. The timing of blood pressure measurement also holds significant importance, as blood pressure follows a natural circadian rhythm. It typically rises in the morning, peaks in the late afternoon, and naturally dips during sleep. After age 65, this rhythm can become irregular. Some older adults experience what is called a non-dipping pattern, where blood pressure fails to sufficiently decrease during sleep. Research from Tohoku University in Japan revealed that seniors with this non-dipping pattern had significantly higher rates of stroke and heart disease. For patients with this pattern, simply adjusting medication timing from morning to night can sometimes be an effective intervention. Therefore, understanding whether a patient is a dipper or a non-dipper is crucial for personalized medication management. Moving to another critical concept, one that reframes the entire discussion on cardiovascular risk in seniors, is the principle known as the J-curve. The J-curve represents a pattern discovered by researchers in large cardiovascular studies, contradicting the assumption that lower blood pressure always means lower risk. When plotting blood pressure values against the risk of heart attack and stroke, one might logically expect to see a straight downward line. The lower the pressure, the better the outcome. However, the data reveals a distinct J-shaped curve. Risk does decrease as blood pressure is lowered from dangerously high levels, but at a certain point, the risk begins to rise again as blood pressure drops below a specific, individualized threshold. The lowest point of risk, the sweet spot or just right zone, is not at the absolute lowest pressure. For seniors, this threshold is critically important. Research published in the journal Lancet, which analyzed data from over 22,000 patients with coronary artery disease, a narrowing of the heart's own blood vessels, found that when diastolic blood pressure, the bottom number, was pushed below 70, the risk of heart attack increased significantly. When the diastolic number dropped below 60, the risk nearly doubled. This phenomenon is a textbook example of the J-curve in action and has specific implications for seniors. The heart muscle itself receives blood only during the relaxation phase of each heartbeat, which corresponds to the diastolic pressure. If this pressure becomes too low, especially in seniors whose coronary arteries may already be narrowed by decades of natural aging and arterial changes, the heart muscle's blood supply becomes insufficient. This lack of adequate irrigation to the heart muscle translates directly into real cardiac events. The goal of blood pressure treatment in seniors, therefore, must not be the lowest possible number, but rather the optimal number, a precise balance that protects the heart by ensuring sufficient perfusion, maintains adequate blood flow to the brain, prevents falls by keeping the patient steady on their feet, and ultimately preserves quality of life. The concept of the J-curve was vividly demonstrated in the case of Robert, a 78-year-old retired engineer from Phoenix, Arizona. Robert was meticulous about his health. He exercised regularly, maintained a healthy diet, and took his medications perfectly as prescribed. However, his cardiologist had been consistently pushing to lower his blood pressure numbers as much as possible, resulting in a diastolic reading that consistently hovered around 62 to 65. Robert began experiencing chest tightness during his morning walks, a symptom he had never previously encountered. After a comprehensive evaluation and a careful medication adjustment guided by the J-curve principle, his diastolic pressure was allowed to rise back up to approximately 76. His chest symptoms resolved completely, allowing him to regain his active lifestyle. 3 months later, he successfully completed a 5K charity walk, a milestone he attributed directly to the change in his blood pressure management strategy. For most adults over 70, emerging research suggests that a systolic pressure between 130 and 150 and a diastolic pressure between 70 and 85 may represent a significantly safer and more beneficial zone than the one-size-fits-all 120/80 target. Finally, we turn to one of the most powerful predictors of cardiovascular risk in older adults, a metric that almost never enters the conversation outside of academic cardiology. The pulse pressure gap. Pulse pressure is simply the numerical difference between your systolic, top, and diastolic, bottom, blood pressure readings. If your reading is 140/80, your pulse pressure is 60. If it's 130/85, your pulse pressure is 45. While this calculation seems like simple arithmetic, it provides profound insight into the health and elasticity of your arteries. A study from the Framingham Heart Study, one of the longest-running cardiovascular research programs in history, found that in adults over 60, a widening pulse pressure was a stronger predictor of heart attack risk than either the systolic or diastolic number alone. Specifically, a pulse pressure greater than 60 was associated with a 32% higher risk of coronary heart disease, independent of the actual blood pressure values. This means that even if your top and bottom numbers individually appear acceptable, a wide gap between them indicates elevated risk. To understand why pulse pressure matters so much for aging bodies, consider the physics of arterial stiffness. As large arteries stiffen with age, a universal process accelerated by inflammation, oxidative stress, and natural wear and tear, they lose their ability to act as shock absorbers. Normally, healthy large arteries expand slightly to absorb the force of each heartbeat, the systolic pressure, and then recoil to maintain pressure between beats, the diastolic pressure. When arteries stiffen, they cannot adequately cushion the force of the heartbeat, causing the systolic pressure to rise. Simultaneously, the lack of elastic recoil causes the diastolic pressure to fall. This widening of the gap between the two numbers is exactly what pulse pressure measures. A wide pulse pressure itself causes further damage to delicate blood vessels, including the small vessels in the brain and the filtering units of the kidneys. After age 75, a person loses approximately 30 to 35% of their large artery elasticity compared to what they had at age 50. While this is a natural physiological process, certain strategies can significantly improve arterial health. Aerobic exercise, such as walking at a moderate pace for 30 minutes 5 days a week, has been shown in trials at the University of Maryland to significantly reduce pulse pressure in adults over 65 by improving arterial compliance, the artery's ability to stretch and recoil. Dietary interventions also play a vital role. Dietary nitrates, found abundantly in beets, arugula, and dark leafy greens, support the production of nitric oxide, a molecule that helps relax and expand blood vessel walls. Magnesium, found in pumpkin seeds, almonds, and dark chocolate, has been shown in multiple studies to modestly but meaningfully reduce arterial stiffness over time. The most empowering action you can take at your next doctor's appointment is to ask not just for your blood pressure numbers, but specifically for your pulse pressure. Calculate it yourself immediately if you have a recent reading by subtracting the bottom number from the top. If that number exceeds 60, it represents a conversation worth having with your healthcare provider. It is a vital window into your arterial age, which can be improved through intentional lifestyle modifications and personalized treatment plans. The overarching lesson here is that independence in older age is not simply a matter of luck or genetics. It is the result of accumulating informed, intentional decisions over time. The individuals who thrive in their 70s, 80s, and beyond are often those who actively participate in their own care, questioning advice that doesn't feel right, seeking out information, and collaborating with their doctors as partners. They are not defined by hitting a perfect number on a chart, but by maintaining their quality of life, their cognitive sharpness, and their physical stability. It is absolutely never too late to begin making informed decisions about your health, especially when it comes to vital functions like blood pressure management. By understanding that a single standardized target like 120/80 may be detrimental to an aging body, you gain a powerful layer of knowledge that can fundamentally change the trajectory of your health or the health of a loved one. The shift from a one-size-fits-all approach to personalized, age-appropriate care is essential for a healthy and vibrant future.